Thank you all for having me here. I'm just trying to decide if I'm going to walk around or I'm going to just stand behind the podium. What do you think? Walk around? Okay. So today, I'm going to talk to you all about comprehensive Parkinson's care. I started this journey in looking after Parkinson's patients about 11 years ago when my team and I realized that there is a need for this kind of care. And we'll explain to you today why and how it works. So today we're going to talk about the complexity of Parkinson's disease and why we need this comprehensive care for older patients. We need to understand the roles of our interprofessional team and to also empower persons with Parkinson's disease and their care partners with tools and tips to live well with Parkinson's. So as you probably know, Parkinson's disease is a fairly common condition, about 1% of the population, and it is actually the fastest growing neurological condition. It even surpasses the growth of Alzheimer's disease. And 82% of people with Parkinson's in Ontario are over 65. In 2011, we have 85,000 people with Parkinson's in Canada, and the number is expected to double by 2031. When we think about Parkinson's, we often think about shaking, stiffness, and slowness. And yes, these are the early symptoms, but as the disease progresses, as probably a lot of you have noticed, there is increasing difficulty with perhaps balance and also freezing of gait, more of a gait disturbance. Parkinson's is a very complex disease, and when we think about it, if you look at the picture, it shows you the tip of the iceberg. When we are thinking about the motor symptoms or physical symptoms of Parkinson's, so those are slowness, stiffness, and shaking, those symptoms come from changes in the substantia nigra of the brain. You probably have heard of the term substantia nigra. It literally means the black bodies in the brain. So in this particular area of the brain, the neurons or the brain cells start to degenerate, and therefore it reduces the dopamine output from this area. But in fact, we know that that is only the tip of the iceberg. The Parkinson's pathology starts to affect many different parts of the brain. As you can see, we can see that there's the pons, all the different parts of the brain, like the amygdala, hypothalamus, cortical areas, and even goes down into the peripheral nervous system. Initially, the changes, as I said, primarily affect the basal ganglia, the substantia nigra. As the disease progresses, these changes can progress to the cortex, which can be responsible for the symptoms of depression, anxiety, cognitive changes, and as well, when it affects the peripheral nerves, for example, those in the autonomic nervous system, then people can get symptoms such as constipation and low blood pressure. So because of the importance and how common these non-physical or non-motor symptoms are, there's actually a guide that has been written by Dr. Pastuma. It's called the Guide to Non-Motor Symptoms in Parkinson's Disease. And you can have access to this via this website that we have on the screen. In the early stages, primarily most patients are dealing with the tremor or the shaking at rest, this muscle stiffness, and the slowness. So those are the hallmark symptoms of Parkinson's. But as the disease progresses, we find that more and more patients may be affected by the so-called non-motor or non-physical symptoms of the disease. And those can include things like autonomic features, which means constipation, low blood pressure, especially when people stand up quickly, lower voice, and so forth. And also, as the disease progresses, there are also more neuropsychiatric symptoms as well. And those are things like depression, anxiety, sleep problems, and cognitive issues. And we know that if you look at the list of symptoms we have on the screen, of course the physical symptoms are challenging. But when you look at those non-physical symptoms, they are sometimes even more challenging. As the disease progresses, it can cause a great deal of caregiver stress and a great deal of deterioration in quality of life for the patients. This is the non-motor questionnaire that we often administer in our clinic, just to let patients sort of keep track of and tell us what non-physical symptoms they're experiencing so we can target them. So I'd like to talk about Parkinson's disease in the older adults. I'm a geriatric specialist by trade, so I became interested in Parkinson's disease about 11, 12 years ago and started training in this area for 6 years at Toronto Western Hospital. And Parkinson's disease in the older adult is particularly challenging because as people age, of course, Parkinson's disease is not necessarily the only issue that they have. They can have many other issues like heart problems, diabetes, stroke, or whatever other condition may be present. And so in addition to the complexity of Parkinson's itself with the motor and non-motor symptoms, the patients are also dealing with all the other chronic diseases and all their other medications. Okay, and this makes the situation particularly challenging because there could be many drug-drug interactions and drug-disease interactions. And I'd like to talk a little bit also about cognitive decline in Parkinson's. We know from the literature that about 80% of patients by 10 years of Parkinson's disease do have some degree of cognitive deficit. It is not a hopeless situation, though. It is not a foregone conclusion. There are many things that you can do to help you live well with the disease, and we'll talk more about that with our interprofessional team. But I'd like to highlight the fact that in cognitive deficits in Parkinson's, primarily it is an attentional deficit and executive function issue, as opposed to memory issue. Because when we think of cognition, a lot of people think about memory only. And in Parkinson's, when people start to have cognitive issues, it's usually not memory first. It's usually trouble, for example, understanding complex situations, maybe some trouble with planning, organization. Depression and anxiety, when untreated, can certainly contribute to cognitive impairment. So if people have difficulty with depression and anxiety, which is quite common in the disease, we know that about 50% of patients during the course of their illness can have depression and or anxiety. Poor sleep, so that includes a lot of different things. That includes having trouble going to sleep, but also sleep disorders such as sleep apnea, and REM sleep behavior disorder, and restless leg syndrome. All these can contribute to fatigue and, of course, then cognitive issues as well. And even medications can contribute to cognitive impairment. Some over-the-counter medications, such as anticholinergic medications like Benadryl or Gravol, which you can easily obtain just in the drugstore, can actually contribute to cognitive issues. Sleeping pills is the other one. And other things that can contribute to cognitive impairment or worsen existing cognitive impairment are social isolation, lack of exercise, as well as hearing loss. Now let's switch gears a little bit. So why are we so focused on comprehensive Parkinson's care? One of the reasons is that we know that Parkinson's patients get hospitalized frequently. 1/3 of Parkinson's patients can get hospitalized per year, and out of these patients, about 50% can be readmitted within a year. So those are pretty big numbers. And we know that hospitalization is, for the most part, a huge risk in terms of functional decline and cognitive decline for patients. So it follows that the best way to deal with this is to prevent hospitalization in the first place. The risk factors for hospitalization include older age, being on more medications, and having more comorbid illnesses, and a high degree of caregiver stress. So about 10 years ago, we realized this problem, and we wanted to have a solution to it. This is the spectrum of services we've got at North Patients. So we have a geriatrics clinic for Parkinson's, which offers interprofessional, comprehensive management of Parkinson's. We have a Living Well with Parkinson's program, which is exercise and education focused for earlier stage Parkinson's. And we have the geriatric day hospital, which is an individualized outpatient rehab sort of plan for the Parkinson's patients. Since our clinic was started in 2007, we have served over 1,000 patients in our community. And there are patients that come from as far as London, Ontario to see us, because we are actually the only geriatric clinic for Parkinson's in Ontario. So what we offer is a comprehensive assessment and management of Parkinson's in terms of all the motor features, all the non-motor or non-physical symptoms, as well as balancing this, taking into account the person as a whole, the psychosocial aspects and their different needs, caregiver stress, and also looking at all their other comorbid illnesses and their medications to try and arrive at a concerted, correct sort of plan or cocktail for each patient. So what we have is a certified geriatrics pharmacist in our clinic, and I'm a care of the elderly physician, as I mentioned, with training in Parkinson's. So with our efforts, we wanted to see how effective it is, really. We offer telephone intervention Monday through Friday, primarily staffed by our pharmacist, Greta. So our patients and caregivers have access to our services really all through the week. Whenever they have any issues with their symptoms or medications, they can call Greta and can expect a phone call back within 24 hours. And we want to see if this service can actually prevent hospitalization. What we found was that when patients call, we classify some of the calls as so-called crisis calls, in that the patient or caregiver says that if this issue is not resolved, we are going to emerge. And we found that over the course of 1 year, we received 300 calls, and a quarter of these calls were crisis calls. And the reason for the calls, the most common reason is actually non-motor symptoms. Some are adverse drug reactions, like meaning side effects of medications, and some are motor fluctuations. And we actually found that with this particular telephone intervention program, we were able to prevent over 90% of emergency room visits in this population. In our population, the average age is 80. About 50% of patients have cognitive challenges or depression. And on average, they're on 10 medications, and they have had Parkinson's for 10 years. So that is a very, very encouraging result, because we're really glad that our service is actually making a big impact on the lives of these patients. So I want to just highlight to you what can happen to patients if they go into hospital. So all the things that could potentially go wrong, so to speak. So this is a common case scenario. We have a 78-year-old man. His name is Gerald. He's a retired banker living with his wife. He came to hospital because he was confused and he had a fall. He has been quite constipated with a hard bowel movement happening every 3 days, and he couldn't pass urine on this occasion. He needed catheterization. And at home, he has had a few medical issues. He's had some seasonal allergies. He's been taking Benadryl, 25 milligrams daily. And for Parkinson's, he's had this for 10 years. He's taking trihexyphenidyl, levodopa, and the levodopa was given 1 tablet 4 times a day at home at 7 o'clock, 12 o'clock, 5 o'clock, and 10 o'clock. But when he's in the hospital, because the hospital administration schedule is often different from the way QID or 4 times a day schedule. So in the hospital, it is given at 9, 2, 6, and 9. So of course, that doesn't necessarily work for Gerald. And he also has high blood pressure, he's on several blood pressure medications. He's on atenolol and ramipril. So those are pretty common medications. And when he came in, we noticed that when he is sitting, his blood pressure was 105 over 68. When he was standing, it drops to 80 over 50. So that is probably one of the reasons for his fall. So how can a comprehensive Parkinson's assessment and management help Gerald in this case? So we can see that the medications, including Benadryl and trihexyphenidyl, they have side effects of causing confusion. And in this case, we can stop these two medications, and that can help Gerald's confusion. We can also change the levodopa schedule back to his home schedule so that it can work better with his symptoms. And in terms of constipation, it is actually a vastly underdiagnosed problem. A lot of people, if you ask gastroenterologists, my husband happens to be one, they will say that people can have 3 bowel movements a day to 3 bowel movements a week, and that's fine. As a Parkinson's specialist, it is not fine to have 3 bowel movements a week. Not fine. Because what happens when people are constipated, the medications do not absorb properly. So that contributes to failure of levodopa and motor fluctuations and wearing off. And so when patients come in and they complain that their medication is not working or they're wearing off, one of the first things I address is always constipation. So in this case, we can manage Gerald's constipation by giving him laxatives, and we also must remove the catheter as soon as possible. And we'll gradually reduce his blood pressure medications, and we can organize follow-up for him at our clinic for Parkinson's. I'd just like to introduce to you what our interprofessional Parkinson's care team includes. So the orange circles, that's pharmacist, and the care of the elderly physician, that's me. So we are the people in the Parkinson's clinic. And the people in the blue circles, that includes physiotherapist, occupational therapist, a mental health nurse, a medical nurse, dietitian, speech-language pathologist, and social worker. So those are the staff that are in our geriatric day hospital. So as you can see, we kind of conceptualize it by thinking that we are surrounding the patient and their caregiver. We want to look after them in this manner. And because of our teamwork, we actually won an award in 2011. It's the Collaborative Team Initiative. There's our team there. We have the Fanny Bernstein Living Well with Parkinson's program, and that's the 8-week exercise and education program. Our primary goal is to empower people with Parkinson's and their caregivers to live well, to recognize Parkinson's symptoms, to understand these symptoms, and to understand the rationale for the different treatments. And we call this sort of hope therapy as well, because we want to instill hope in people, that even with this diagnosis that might sound very scary, you can still have hope because you can still live well. There's a lot of things that you can do. And our day hospital is for more advanced patients. It's a 6 to 10 week program that involves an individualized program by our physiotherapist and allied health team working on gait and balance training. For example, there are many strategies for freezing of gait and fall prevention. And also our pharmacist, Greta, works on medication management and monitoring of side effects of the medications and medication titration and so forth. And our social worker and mental health nurse offer the psychosocial support that is so necessary. So I've put some geriatric services resources on the screen for you in your area. I realize that there's no geriatric specialist in your area, particularly specializing in Parkinson's. But many of you already, and as I've pointed out to you, Parkinson's is such a complex condition, and if you're a little bit older, you may have other conditions other than Parkinson's. So it often is very helpful to have that sort of comprehensive view of your whole person and your whole condition so that you can really live as well as possible. So now I'm going to pass the mic to Roula, our social worker. Thank you.
This is going to be funny. Thank you. All right. I hope everybody can see me because I want to use the podium. Good afternoon, everybody. Oh, goodness. Good afternoon. I am just so amazed and inspired by the turnout today. So good for you. This is wonderful to see the amount of people out here today. So just continuing on from Dr. Lee's talk, I'm going to focus more on what a social worker would do in our clinics and in our day hospital. So as a social worker, when seeing a person with PD, we would look at things like dealing with the diagnosis, helping clients accept and adjust to a new norm, the importance of communication, mood issues and how they can impact function, as Dr. Lee has already mentioned, mood and anxiety, helping clients adopt a daily routine, educating clients and families on resources and the services in their community, and thinking about future planning. So can I get an idea of how many people in this room have been diagnosed with Parkinson's in the past 2 years? Hands up if you, all right. So it's very important that many times when clients with PD are seen, there's a lot of focus on the physical symptoms. And sometimes we may ignore the psychological, emotional responses to this illness. It's important to take stock of your strengths and help maintain, in order to help you maintain control. And I think as Dr. Lee already said, PD does not have to define you. You can still live well with Parkinson's. And it's important to try not to anticipate the future. Everyone's journey is very different. No two people will experience Parkinson's the same. So it can be quite unsettling, I think. There are so many competing tasks that you will be asked to do. Things like, accepting your diagnosis and moving forward, dealing with the emotional aspect, trying to feel control and in control, looking for things to help you live well, starting to think about the future. And that is a lot of noise in your head. So let's go back a minute and think about when you were first diagnosed with PD. What were some of the emotions that you felt? This is just a few that we see, that I hear about. I'm sure some of you have experienced at least one, if not more than that. And just normal to feel shock to a traumatic event, such as a diagnosis of PD, anger, a fear of the future. And interestingly enough, sometimes people feel relief, and the relief is focused around just having an idea finally of putting a label on what's going on for them. And with that, we will have some anticipated changes and concerns about things that are going to change in our lives. The roles that we keep. Will we be able to maintain them? Will we be able to, still be a volunteer, still work, still be an employer? Will I be able to take care of grandchildren? And these are things that are very legitimate concerns and changes that may happen. So at some point for some individuals with PD, this worry, fear, sense of hopelessness may lead to anxiety and or depression. And this may affect your sleep, your appetite, your concentration, your energy level, your interest. And many times we're not aware that we are feeling the depth of our feeling of sadness. And it's important to be able to trust the people around you. To be able to listen to them if they were to say to you, I think you are feeling depressed. Because it's so very important to get treatment, whether it is speaking to a counselor or a therapist, or whether it's speaking to your healthcare professional for medication, because things don't have to be, you don't have to feel that bad. And at some point, interestingly enough, I don't know if you've heard of Dr. Sonia Mathur, who is a family physician and has early onset Parkinson's disease. She talks about the toolbox, and this toolbox, she says, it is our toolbox. Each of us has one. It is the way that we, do business in our lives. And in the beginning, pre-Parkinson's, we knew the game rules. We were a productive part of society, or felt that way. We had a game plan. And interestingly enough, after Parkinson's, we don't have that same kind of game plan. We are having to learn new things. We are having to adopt a new care plan. And it's very, very important that at some point you have to abandon the fear of the future in order to live in your present. Life is happening right now. It's so very, very important, instead of worrying about what's going to happen, to live the right now. So when we see clients in our program, one of the things that we really want to do is empower them to put together a foundation, knowledge and resources. And we like to sort of think about, packing a suitcase for your Parkinson's journey. What would you put in that suitcase? And it's interesting that you put things in that suitcase that are going to be meaningful and helpful to you. Because again, each person is different. You know your own body, you know what works best for you, and and that is one form of control for you. So we like to have our clients build this foundation of strategies to include things like maintaining a good exercise regime, and it can be anything. But I think what we strongly encourage you is to be consistent, to participate in regular activity. And that can be anything from Tai Chi, yoga, dancing with Parkinson's, the rock steady, anything that's going to ensure that you maintain activity. Finding your optimum medication schedule. Find what works best for you, work with your healthcare professionals, and follow that regime. So very important. Have ways to de-stress. We know that anxiety can affect function, so it's so very important to have things to go to so that you can alleviate stress and anxiety. Gather a good healthcare team. Be comfortable with the people that are taking care of you, that you feel comfortable that you can ask questions, that you can dialogue with. And keep a journal or a daily log. And this is really helpful, and Greta will talk about this at the end, preparing for your physician appointment. It's interesting that, I don't remember what I did 3 weeks ago. So it's important to document what the kind of day that you're having on a day-to-day basis. Did your medications work? Did you have a good day? Did you have more on or off periods? What did you do for activity? And I think it's really important to be able to have that, to look at what I did, but also to be able to bring that back to your doctor's appointment. Surround yourself with strong family or social support networks. And this is key, because these are the people that are going to walk this journey with you. It's important to have people that you trust, people that are going to go the distance with you, that you feel comfortable with. And there's this whole other piece about how do I tell people? Who do I tell? When do I tell them? And we've had many clients that choose not to tell family until they have to. They choose not to confide in friends until they have to, until the symptoms start to show themselves. So I think you don't have to tell everyone, but I think it's important to at least have a few people around you that will be there for you. Get connected. Know what the resources are in your area. Get connected. Being here today is one way of being connected and collaborating and being with other people that you can speak to and you can hear their own stories. Okay. All right, so in order to go from shock and fear, we need to move to empowerment. So we need to learn new strategies. And just a couple of suggestions. Oops. Take responsibility. You know your own body. You know what works best for you. Collaborate with others. That's what you're doing here today. Adhere to decisions. If you're going to exercise, exercise regularly. If you're going to take your medications, follow the recommended regime. Be a smart healthcare consumer. Know what you need to know about this illness. Research, learn to adjust. And it's interesting that we see a lot of people in our clinic and the day hospital where people believe that they need to do things the way that they used to do things. And I'm not sure if everybody in this room is still doing everything that they used to do, but it's important to know when to adjust. So say you can't do things in the early morning anymore, you do them in the afternoon. Say you break activities up and you take a break in between. You can still do the things that you used to do. It just takes a little bit of adjustment. And the most important one, I think, just generally for everyone, is communicate. Communicate with those around you, communicate with your care partners. Feel comfortable to do that so that you don't isolate yourself. I wanted to show you an example. We talk about all these different strategies that we offer and in building a foundation. This would be an example of what we call a daily routine. For example, we get up and get washed. We take our 7 a.m. medications. We get dressed. We would participate in some sort of exercises, have breakfast, take our next medication dose, participate in some LSVT exercise, have lunch, our 3 p.m. medications, and so on and so on. And I think it's important to note it becomes very structured, but very, very helpful. You know when your on periods are, you know when you can participate in activities, and you're going to be able to enjoy those activities. We'll talk a little bit about community resources and staying connected. 2 very important resources I think I need to mention that everybody should know and be aware of. One is your local Parkinson Society. And for this area, it's the Southwestern Parkinson Society, because they are a wealth of information. They are education, they offer resources, support groups, conferences such as this. They also have information on specialized activities such as the Rocksteady boxing and the Dancing with Parkinson's, as well as your local LIN, which is an OHIP-funded service with a wide range of healthcare services, which include things like physio, home safety, speech-language pathology, physio, I think I already said that, nursing. So just 2 very important resources to know. I have included the websites at the end. I just want to make mention of the people that are here on the journey with you. And these are your care partners. I think they need to be acknowledged. And I think sometimes these individuals get so caught up in making sure that things move smoothly for you that they sometimes ignore their own needs. And I think it's important to also ensure that they are taking care of themselves. There's communication back and forth. You are aware of how they're feeling. They're aware of how you're feeling, because obviously nobody can read minds. And it's important, I always ask that people walk in each other's shoes. I'm going to skip that. You can read about it. Just lastly, I wanted to talk a little bit about future planning. There's so much to say, but we're trying to cut it down, so forgive me. Just a couple of things in light of looking to the future and sort of making things simpler, more organized for you. Think about things that you can do to make life simpler. Consider starting to put your affairs in order, completing your powers of attorney, your advance directives, your wills. Document things and inform the people that are going to work with you on these things, your power of attorney. Have them understand what your wishes are. Start making things a little easier. For instance, consolidating bank accounts, direct deposit, automatic withdrawals, anything that's going to make things easier. Start talking to family, friends, employers if people are working, just about the PD, so that people can understand, and build a strong support network and get connected and stay connected, I think is that final message. All right, the resources that I promised, I'm going to pass it on to our physiotherapist. Thank you.
Hello. Thank you. I'm very pleased to be with all of you today sharing in this wonderful Education Day. As a physiotherapist, I have the opportunity to assess and see the many challenges of people living with Parkinson's. Among current treatment for Parkinson's, I will be discussing some of the benefits and roles of Parkinson's, some of the walking challenges and strategies, tips on getting in and out of a chair, and I may have you do that today if we have some time, and some Parkinson's-specific exercise programs, namely LSVT and POWER, Parkinson Wellness Recovery. So why is exercise so important for people? Research shows that people with Parkinson's who exercise do better. And in fact, there is huge value in starting early. Think of exercise as medicine. It's shown to be neuroprotective, meaning that it can make changes in the brain and actually slow the disease process down. Improving posture, which tends to be, along with the process of the disease, we tend to see some forward posture. If we can straighten that out and work on the posture early on, we may actually alleviate some of the problems associated with speech and swallowing. As well, there's improved movement in muscles and joints, so things are moving better overall. Improved balance, which leads to decreased falls. Improved overall fitness. Independence in your daily activities, which is what everybody's working towards. Improved mood and self-esteem. And even the opportunity for decreased constipation. A very practical tip. So what are the types of exercise? So more than the types of exercise, it's important to engage in physical activity on a daily basis. An exercise program should include stretching and flexibility, strengthening, aerobic conditioning, which there has been more and more research on, particularly with humans, as opposed to most of our research which is done with animals. So that's very exciting. There is apparently quite a bit of research looking towards the type of exercise you do as far as aerobic exercise and even the benefit of working at a high intensity and perhaps even interval training. Balance and coordination are other very important forms, working on posture, of course, continuously, and of course movement strategies such as Parkinson's, such as LSVT and POWER. In addition to that are boxing, which has also got some recent attention, and I think the reason for that is because these exercises all incorporate large amplitude and large effort movements. Changes in walking are a hallmark in people with Parkinson's. Reduced speed and amplitude and reduced motion in the trunk are the main challenges. Freezing gait is a temporary, involuntary inability to move, and that's really when your feet feel almost stuck to the ground. The automatic pilot in the brain stops, giving the instruction to step. The cause is unknown, but we do know that it is a risk factor for falls. Festination, also referred to as shuffling gait, is an involuntary quickening of gait with short steps, often on tiptoe. The center of gravity comes too far over the base of support, and then the feet cannot keep up with that. Freezing of gait is often triggered with the onset of walking, but can also occur with various other movements, such as turning or changing direction, narrow spaces, cluttered or crowded environments, doorways and elevators, uneven, unpredictable terrain, change in footing, and when approaching a target, such as a chair or an obstacle, when distracted or multitasking, and also when nervous or stressed. Now we'd like to play a video. So in the video you just saw, the gentleman used a visual cue, which was tape on the floor, and by doing that, he was able to override the freezing of gait. And interestingly, that was during the off period. So what are some other visual cues that we can use? So at home, you can actually tape doorways or entranceways to rooms in your home. People can also tape stairs, although as it turns out, people with Parkinson's are very task-specific learners, so for whatever reason, stairs are usually a lot easier than walking. But if we use some of those cues, then perhaps that could improve things. Other things you can do is use a laser pointer, as you can see in the photograph. which is basically a beam across the floor, which is used as a cue that individuals can concentrate on, which is a different task of gait. Looking beyond the obstacle is another cue, and mimicking the caregiver. So very often we'll have a caregiver walking beside their spouse or whoever it is that they're with, and they can actually show these large steps, and that person can follow along. There's also auditory cues. So you may have heard of counting 1, 2, 3, 4, particularly in a loud voice, or marching on the spot before then moving. Music can also be very helpful, so singing a rhythmic tune, keeping a metronome on you. In fact, you can download it as an app on your phone. You can keep it in your pocket when you're walking, and also taking big steps. Some attentional cues. So this is basically paying attention to the action and your body awareness. So movement rehearsal is very good. Practicing big steps, telling yourself to start with your heel first, so heel strike, shifting your weight side to side, bending your knees up and down, stepping sideways before stepping forward, and turning in an arc, so around something, rather than going straight to the target to avoid then having to turn on the spot. Equipment, as we've already mentioned, there are walkers, there are canes that actually come with something with the laser attached to them, but you can also buy a mechanism that has that laser connected to it, and you can put that on any walker. There is also something called a U-step, which is a walker that was directly made for people that have walking concerns, and you can use that with or without the laser. Slow down brakes for people who tend to have their walker get away from them because it's hard to control their speed is another option, and really whatever works. I've heard some very creative things over the years. Okay, we're going to talk a little bit about 3 steps to getting out of a chair. However, we're going to pass that for the moment because I'd like to try that with all of you today. I'll see if my team gives me the 2 minutes up, but hopefully I can stay within my time. Okay, so LSVT. There are some very good Parkinson-specific exercises out there. They specialize in programs. They're specialized programs that actually target the symptoms directly associated with Parkinson's. LSVT is an evidence-based exercise program which targets high-amplitude movements, so large movements. It focuses on neuroplasticity, otherwise known as brain changes, and it was developed from principles of LSVT Loud, which was created to improve low or soft voice. And it was so effective that they decided to try it in the motor system, and so LSVT Big was developed. The goal was to re-educate the brain's ability to better coordinate physical function. What are some of the other benefits of LSVT? Is that it teaches the correct amount of effort required to produce normal movements. So in individuals with Parkinson's, sometimes their internal cueing is not functioning the way it should. And so by teaching these big exercises and teaching them how to move bigger can actually help to recalibrate the system. This translates into bigger movements and also, of course, into real-world activities. It leads to faster walking with bigger steps, improved balance, and increased trunk rotation. It also, and most importantly, empowers people with Parkinson's to see their potential to improve. In 2010, Dr. Farley founded POWER, Parkinson Wellness Recovery. She had previously developed LSVT, but wanted a more flexible program and an approach that targeted foundational movements, which I'll demonstrate shortly, called power moves, to counteract the deficits shown to interfere with everyday mobility. Her mission was to provide individuals access to physiological tools that promise to slow disease progression, improve symptoms, restore function, increase longevity, and improve quality of life. The POWER vision includes communities where individuals with Parkinson's treat exercise as medicine. So where are we? Yesterday, treatment was aimed at compensation, bypassing deficits, training strategies to make everyday life simple, not challenging the physical or cognitive effort. Today, there are numerous studies showing neuroplasticity in animal models of Parkinson's and exercise, how forced use beyond self-selected effort creates better movement, and the importance of starting early and maintaining continuous threshold. Tomorrow, we hope for a revolution of using exercise as medicine to slow disease progression, and hopefully this is where we're going. Exercise for brain change represents Dr. Farley's research principles about how to exercise to promote brain changes and improve function. The techniques require use of the following system. The first system being physical effort. This progressively challenges motor power beyond self-selected effort. It requires an individual to work at 8 on 10 or 80% effort to create these bigger, faster, and more fluid movements. Then we look at cognitive engagement. This challenged the complexity of movement, dividing attention for common multitask situations. So from simpler set switching, like getting up, going to the kitchen, turning around, opening the fridge, going back into the other room with whatever it is that you happen to be holding. These are all things that are very important and require a lot of problem solving. So, and they can be as simple as that, as looking back into the sports that you love, like table tennis. The important is that practicing movements with real-world distraction can have a carryover effect. Attentional focus requires attention to action. It teaches body awareness, planning, and problem solving. It helps with the mismatched perception that interferes with self-correction and carryover, i.e. bigger, faster, normal movements feel too big and fast for people with Parkinson's. So again, then we talk about that recalibration. And emotional engagement. Motivation is augmented by rewarding and empowering individuals. Making activity meaningful and function exercise is really the way we all need to be able to be motivated to do more. Okay, so the power moves are really based on 4 key movements, and I'm going to actually attempt to demonstrate them, and then we're going to do these together. So they are basically done in 5 positions. So they can be done in prone, which is on your stomach, in supine on your back, on all 4, so hands and knees, and in sitting and standing. And for the purpose of demonstration, I'm going to do this in standing. Let's see if this is still working. It's still working. Okay. Basically, the first thing we do, and imagine that you can do these in lying, sitting, standing. I'm going to do this in standing, and then we're going to practice a little bit, but not yet. So this is the power up. So look at what I've done here. I've just used my extensors. I've taken myself out of that forward posture, and I've done a power up with big effort, big amplitude. And if I continue to do that, hopefully that will extrapolate into every day. The next one is called a twist. So I'm twisting and opening and twisting and opening. You can see I'm getting rotation, which we know is very tricky. I'm keeping the trunk open. I'm doing a big movement, and imagine if I was lying in bed and I had to reach over to be able to go on my side to get out of bed, or I had to reach over for my pillow, right? The other one is called the rock, and it's basically weight shift. And this is the one I'm going to have you try, but not yet. And basically, we're going to also add the arms. So by adding the arms, right away, we're doing more than one thing. So we're multitasking. And then I'm going to have you do things like look at your hands and then perhaps even say a few things as we're doing that. So you can see how these tasks become quite complex, but really this is how we activate things in the brain. Okay, and the other one. To see my picture, we did the power up. Oh yes, and the step out, my personal favorite. The step out, it's almost like a fencing move, but I've actually taken my foot off and reached out to the side. And you can see that that looks easy, but we all know that's really not that easy. And then I'm going to add a ta-da at the end. Ta-da! Good. And I can't have all this fun by myself, so I'm going to actually go back, and let's see, whoever would like to try this, the first thing we do is I'm going to have you practice getting out of a chair first. The tips as promised. Now, if you can't see me, because I want you all facing your table, whoever would like to try this. So I'd like everybody facing in. So you're holding and you're close to the table for safety. Please, caregivers or whoever's around, we want to keep everybody safe today. So I'll just talk you through it. So these are just a few tips. Are we good? Just a few tips to get out of a chair. So the first thing we're going to do is we're going to slide our hips to the front of the chair, If you have taut, you can also lean back and slide forward. It's my little trick, okay? Then we're going to sit up nice and tall. Open our feet wider than hip width apart to keep a wide base of support. Knees are bent and feet are bent. So really, if I look at my knees, I can't even see my toes. Your feet are right back. Then, we don't have armrests, so do your best here. You're going to put your hands on the actual chair. Lean forward. This could be the most important part. Nose over toes to push yourself up. Was that easy? If it wasn't easy, I'm going to have you do it again, because it should be easy, because if your weight is in the right position. Okay, for those of you still standing, let's try it again, everybody. So we're going to slide the hips to the front. Put your hands on your chair. Knees are bent. Nose over toes. Good. That looked easier the second time. Good. And then all I'm going to have you do is a little weight shift. Okay, so we're shifting to the right leg, to the left leg. And I want you all to stay on the same side, because there's other people in the room. We don't want to knock anybody over. Good. Now we're going to add the arms right and left and right and left and right and left. Good. Now, if you can, look at your hands. So look at your hands. We're adding what we call a boost. And look and look and look. Good. Now let's do the 12 months of the year. Let's hear it. January, February, March, April, May, June, July, August, September, October. Nice. I tricked you. Okay, very nice. Okay, to sit down, hands on the chair, make sure the chair is close behind you, and lower yourself. Excellent job. Oops. I think I may have lost. There we go. Thank you. Okay. That was fun. Okay, I was just going to finish off. All right, so imagine if you're doing that, and you can also stay engaged while you do these exercises, including the amplitude. You can actually target the symptoms, including the rigidity, the bradykinesia, and all the challenges of coordination, balance, attention, and emotion. So I'm going to leave you with this slide. Make function exercise. Work hard, do more, move bigger and faster every day. There's also a website at the bottom of the screen, and feel free to have a look at this website. They actually offer these exercises for free, which is really wonderful about power. And also, should you decide to pursue a practitioner, they should have lists for you as well. Thank you very much.
All right, I'm so glad to be the speaker right after Renee, because after all this movement, everybody's wide awake. Okay, so about the slides, we'll be sending the PDF file to the Southwestern Parkinson Society, so don't worry about taking notes, and I know we have a lot of useful resource here, so please request a copy of our slide, or maybe they post it on the site, whatever easier. So my name is Greta, I'm the pharmacist, and I have been so blessed with my job. It's really give me a lot of joy to see the little tips that we provide to people can make such a huge difference in their life and the quality of life. And so my talk today, I focused a little bit about how to maximize the medication. Now, I'm just curious, among our audience, how many of you are currently on levodopa, or the other name is like Cinemed or levocarb? Okay, all right, that's the majority, right? Okay, now levodopa was being developed in the 60s. So we're lucky in a way that this drug's been around and really make a huge difference. So I think going back to the Parkinson 101, we all know it's because of our brain cells not producing enough dopamine. So that's why we have to have supplement. So levodopa is the one that becomes dopamine. So I always use the analogy like diabetic patient. You know, the reason they have diabetes because the pancreas is not producing insulin. But we are lucky, we don't have to inject, right? So today I'll talk about how to maximize the benefit of levodopa and also to encourage everybody and some strategy to make it easier for us to adhere to our medication. Like the doctors spend a lot of time to diagnose and give you, here's the prescription, but sometimes it's not even filled, or maybe it's still sitting in the cupboard, it's not being taken. So the problem is not solved. So I'll get into that. And also some of the information may be relevant. Hopefully no one needs to use the hospital facility, but if one day we need to go to the hospital, what are the strategies that we can use to avoid the complication? And also how to best prepare for your next doctor's appointment. Okay, now how many of you ever experienced one morning you take your levodopa, but it doesn't seem to work? Did that ever happen to you? Some people maybe nodding their head. Yeah, we don't know why, right? And I love to make sure people take the pills on schedule. You know why? A lot of people tell me, oh, I don't want to use the alarm because I found it annoying. I just wait till my symptoms resurface, then I take my pill. So every time my body is like a clock. It will tell me when to take my pill. So every time when I feel the symptom, I take my pill. But I go, no, no, no. When you wait till your symptom resurface, it makes you feel uncomfortable. You're starting to keep feeling the symptoms. Like we should have quality of life without feeling the symptoms all the time. So the best way is to find out what is the best schedule for your pills. So you put on your iPhone, set the alarm, and then the alarm will remind you to take the pill before you suffer for those symptoms again. Because these symptoms sometimes can make you nervous, uncomfortable. So one of the simple strategy is to just have a lined paper. You draw a whole bunch of boxes, and you have Monday, Tuesday, Wednesday for each row. And as you go across the schedule, so you start your morning, you can partition like from 6 o'clock in the morning, depends on what time you wake up, but 30 minutes interval. So every day morning, I take my pill on time, all right? Now, this is a tricky question. What is the right time to take my levodopa? The reason why I focus a lot on levodopa because it's the #1 drug, and everybody eventually need to be on levodopa. So levodopa doesn't last in our body forever. So that's why the schedule is so critical. So usually when the doctor tells you, okay, take the pill 3 times a day, and I have people come back to me, some people take it every 8 hours, and some people take it all in the morning, and some people kind of a different schedule, because the doctor never specified. So usually when the doctor says 3 times a day, the best will be at least half an hour to 1 hour before your 3 meals. Okay, but people say, well, I have my breakfast really late. Then see if you can space it out so your 3 meals, okay? So roughly about every 5 hours or so, 5 to 6 hours, okay? When we sleep, we usually don't need as much dopamine. So spread that out during your waking time and have a schedule, all right? So when you have the schedule, you can use a yellow highlighter. So put down, okay, these are the time I take my pills, all right? So set it on your phone, so it will beep, okay, time to take your pill. Don't wait for the symptoms, okay? People tend to say, I want to maximize so that I wait until later. But no, the idea is you keep a schedule and do a little research on your own body. So basically, you mark down the time, you take the pill, you take according to the schedule, and then you monitor your symptoms. So the symptoms, as Dr. Lee mentioned, is the slow movement, muscle stiffness, right? So when you move your wrist, do you feel like, is it smooth or is it like a little bit stiff? When you try to get out from the chair, you use the strategy, make it easier, but you still find it really slow to get up from the chair. Much harder. It's like everything in slow motion. Okay, so that's when you mark the X on that half-hour interval. So if you do that every day, and every time when you take your pills, you kind of check yourself, okay, is my pills working? So if it's working great, then you don't have to mark anything. But if it's slow, stiff, and maybe more tremor, then you mark the X. Now, tremor is a funny symptom. Not everybody experiences tremor. If I'm nervous, if I'm talking to 250 people, my hand will shake more. So your mood can affect your tremor. So tremor is not the best judgment. So I always look at slow movement and muscle stiffness. So when you do that for a few days, and you start to see a pattern. So when I have a schedule like this one, and I have a whole bunch of X after I take my pill, what does it tell me? It actually shows my pill is not working fast enough. Then I start to wonder why my pill is not working fast enough. I take it on schedule, and oh, someone pointed out to me, I shouldn't have my full big breakfast first. So what happened is the pill is not absorbed in the stomach. It is absorbed in the small bowel. Nobody told me that. It is the truth. So what happened is when you have a big meal, you're creating a traffic jam. It's like when we come here on 401. So same here. When you have a full breakfast, it's going to take forever for your levodopa go from the stomach to the small bowel, right? So no wonder it doesn't work fast enough. And also depends on what you eat. If you take your pill with a glass of milk or with your porridge with milk, and milk has protein. So proteins such as your egg, your meat, your ham, your tuna, cheese. So there's a lot of protein-rich food in your meal. And if you have it at the same time, that can also affect the absorption. So how the pill being absorbed in the bowel, it has a special carrier. It's like a bus carry people over. So when you have a lot of people, it takes a long time for these people to get across. So same thing, when you have protein in a small form called amino acid, it will compete with the levodopa being carried across through the small bowel to get to our bloodstream. So there's two factors. Number one is if you have a full meal, it will slow down. If there's a lot of protein, it also affects the absorption. So how can I get the best outcome is to space it out. Your body needs protein to build muscle mass. So make sure you have your pill at least half to 1 hour before your meal with a full glass of liquid like such as water or juice, not milk. So that way your pill will be transported right to the bowel and get absorbed very fast. Now, Dr. Lee also mentioned constipation. Constipation is a huge business for our patient here. A lot of time people say, I have constipations for years, even before I discovered Parkinson's. So constipation is one of the early symptoms of Parkinson's because it slows down everything, even our internal bowel movement. So if you have constipation, it can be a problem. So, sorry, I have to bring this up after our lovely meal. But the Bristol stool chart is such a useful tool because even when people are eating every day, such as if people have type 1 or type 2 stool, that still means constipation, even though you have that every day. So what does the hard, lumpy stool indicate? That means the stool's been sitting around in the colon for a long time. So sometimes we forget our anatomy. The colon is connected to your small bowel. And the small bowel, that's where it absorbs the levodopa. So if this is all plugged up, not moving, do you think your small bowel is going to move? If it doesn't move, it's not going to absorb your pill as well. So we have to pay attention to our bowel movement. So make sure the stool is not hard. So ideal is type 4, okay? So how do we manage that? So your doctor might have told you about Laxaday or Restore-Lax. So this is different from our psyllium, the fiber type of treatment. This is the powder that brings the liquid that you drink to the colon. So people say, well, I drink a lot of water, but my stool is still hard. The problem is when you just drink fluid, it goes to the bladder. You want the fluid to go to the colon. That's how this magic powder works. Okay? So the secret is to use every day on a regular basis. You don't need a lot. You can adjust maybe 1 teaspoonful to 1 tablespoonful, depends on how you feel that day. And sometimes even when you have soft stool, but you still couldn't get the bowel movement properly, then you may need a little Senecot. So when we take care of that, your levodopa will work much faster. Now, continue on with the schedule, and if you find the symptom seem to occur before my next dose, and some people may feel even more nervous or even trouble breathing or short of breath before the dose is due. And what's going on? Does it mean my levodopa is not working anymore? That's not the case. It just means the progression of the disease sometimes make a demand on more levodopa or more frequently. So when you plot your table and you find a lot of X before your dosing time, then maybe it's time to discuss that with your doctor. So this graph just highlights whenever you take a pill, your drug level goes up. But your body has a lot of enzyme to remove the drug, so the drug level naturally goes down. If it goes down further, the symptom will resurface. So every day, it kind of go up and down, depends on the time you take the pill. So initially, when we first diagnosed with Parkinson's, our brain still produces a lot of dopamine. So if we're short of levodopa, we don't feel anything. But as the disease progresses, then our bodies, the brain cell, is not able to produce enough dopamine or not able to store it. So that's why your body feel the symptoms coming back sooner than before. So it's not because the drug is not working, it's just you lose your own natural dopamine. So the way to manage wearing off, talk to your doctor. We can always move the schedule maybe half an hour earlier and see if that helps. Or the doctor may add extra dose instead of 3 times a day, maybe 4 times a day. And also there's certain drugs such as rosagiline that require the EAP approval for drug benefit for seniors, or adding entacapone that will extend the benefit of levodopa. For people over the age of 65, we don't recommend dopamine agonists, even though there's a convenient patch, but these dopamine agonists increase the risk for cognitive changes like confusion in the mind and dizziness and drowsiness. Okay, so change gear to about medication non-adherence. So there's a study actually found less than 38% of people take the levodopa on time or on schedule. All right, so that's why they find challenging to manage the Parkinson's. And also, a lot of people don't even know why they take these pills. So I think spouse, caregiver, it is so important that you know what pills your loved one is taking, because when they understand the purpose for the pill, then they're more likely to adhere to it and make it to a routine. As Roula was talking about, one of the important tools is set up a routine. Now, how many of you forget to brush your teeth this morning? No one, because it's a routine, right? So once you have a routine for exercise, routine for your pill, and a routine for your pill, then it's so much better to do it this way to manage your condition. Now, I understand when we first got the diagnosis, nobody's happy about the diagnosis of Parkinson's. But sometimes over the months and years, if your friends or family notice he's different or she's different, she doesn't like to socialize, she's kind of isolating herself, it's just the change in mood and personality, sometimes it could be the lack of serotonin and norepinephrine in our brain. Remember, our brain produces dopamine, but it also produces serotonin and norepinephrine. So I always advocate, if that's the case, talk to your doctor and they will assess your symptoms. So if you find you're losing motivations, losing ability to have joy, and poor sleep, and even affect your appetite, I know I'm supposed to do exercise, but I don't feel like doing it. So all these symptoms happen for a long time, then you may need a little supplement, all right? So I don't call that antidepressants or mood pill. Pills is very depressing already. I call that a supplement. If you take a vitamin D supplement, why don't you take a little serotonin supplement? What's the difference? right? If it make you feel better, why suffer? So there's a lot of gadgets, and I also know this is a pamphlet. I'm Spencer, and little gadget to make it easier not to miss your pills. So visit one of the booths our sponsor. And if you go to hospital, there's something we need to know. All right, so hospital, as Dr. Lee mentioned, hospital has their own schedule for the pill. So make sure as soon as you get to the hospital, tell people, this is my schedule, because every patient is different. All right, our body needs levodopa differently. And also, watch how certain medication can make Parkinson's worse. So make sure you have this little paper with you. Don't give me these drugs, because that will make my Parkinson worse. So typically, medications for nausea, and you can use ginger pill, candies, or ondansetron. These are much safer for Parkinson's. Or use quetiapine if needed for hallucination. All right, so last point I want to mention is how to prepare for your next doctor's appointment. Okay, so one tool, as I showed to you, the mobility diary, fill that up for 1 to 2 weeks. So if you don't see a lot of aches, that means you may keep your schedule the same. Or if there's a lot of aches, then talk to your doctor. You see a trend, a pattern. And also important to bring a friend or someone with you, because it's important to jot down all the notes. And also make sure you report to your doctor. Any new medication being added was a new symptom. And I love people to bring a bag of pills so that the doctor knows exactly what you're taking. Okay, so now it's time for a panel discussion.